to move on to the afternoon session, I would like to thank Dr. Jocelyn Karam for coming to, she's all the way from Maimonides to give us the afternoon plenary session. Dr. Karam is Director of the Division of Endocrinology at Maimonides Medical Center, the affiliate site program director for the Fellowship and Associate Professor of Medicine at SUNY Downstate. She's a clinician, a teacher, and a scholastic. Her academic contributions include peer review articles, book chapters, abstracts, invited talks with a focus on diabetes, obesity, diabetes prevention, and thyroid disorders. And this afternoon, she's going to speak on treating diabetes in patients with kidney transplant, emerging role of GLP-1 receptor agonists, and SGLT2 inhibitors. Dr. Karam?
All right, good afternoon, everyone, and thank you for the introduction, and thank you for this opportunity to participate in this important symposium. I'm always very happy to be here. It's the place where I trained, and I have a lot of good people who have trained me and mentored me in this place. So thank you for the invite. So today I will be talking about, actually, it was a learning experience for me doing all that review of literature that we have about treating patients with kidney transplant, with the new diabetes agents that we're using so much now in the patients with diabetes. I have no disclosures. These are the objectives of my talk, and the outline will be, in the first section, I will be reviewing diabetes in patients who are recipients of kidney transplants. And then I will have two sections, one on GLP-1 receptor analogs and another one on SGLT2 inhibitors, where first I will talk a little bit about what we know about the use of these medications in general diabetes population, and then I will look closer into what we know about their use in kidney transplant recipients. So first, diabetes in patients with kidney transplants. And if you see patients who have received kidney transplants, this is going to be a very common disease that you will have to address with them. Why? First, before they get to require a kidney transplant, it's estimated that about 20 to 38% of these patients undergoing transplantation have already type 2 diabetes. And then right post-operatively, as you probably know, the patients are very likely to have severe hyperglycemia because of the stress of the surgery, the steroid use. It's estimated actually that almost 90% of them will have hyperglycemia, even with no pre-existing history of diabetes, because of the procedure. But then what we will focus on today is this group of patients with post-transplantation diabetes mellitus. And what that means, these patients could be either patients who had diabetes that was undiagnosed previously, and I was actually surprised in reading that some centers do not screen for diabetes before transplantation, so it could be undiagnosed, or it could be just a new onset diabetes that happened because of the transplantation. And it's basically the consequences of the transplantation itself and mostly of the immunosuppressant that can induce diabetes. So this group of patients who have now diabetes after the transplant is estimated to be around 18 to 33%. So almost 1 out of 3 patients who are undergoing kidney transplantation will have diabetes. So if you add this group to the group who had already existing diabetes before the transplant, it's more than half of these patients who have diabetes. And this is really what highlights the importance of this topic. The risk factor of developing diabetes after transplantation are several. Some important ones are the immunosuppressive agents that are used. We know steroids cause hyperglycemia, and it's a dose-related effect. In kidney transplant patients, immunosuppressants, specifically the tacrolimus and the cyclosporin, which are the calcineurin inhibitors, are known to cause direct toxicity to beta cells. Sirolimus is known to cause insulin resistance, whereas AZT, MMF, and belatacept are not known to cause diabetes. Patients who have had prediabetes before the procedure or who developed hyperglycemia right after the procedure are more likely to develop diabetes afterwards. Patients with obesity, patients who have concomitant infections with HCV or CMV. And then we have the non-modifiable risk factors of diabetes that we know, which are age, ethnicity, history of gestational diabetes, and family history. And specific to transplant population, non-modifiable risk factors include increased HLA mismatching, male and deceased donor allograft, which is controversial. There are really controversial studies about that. So it's important once the patient receives a transplant, even when they don't have history of diabetes, to screen them for diabetes because of that post-transplant diabetes risk of almost 30%. The screening would be, what experts recommend, fasting blood glucose weekly for 4 weeks, then at 3 months, 6 months, and 12 months, and then yearly afterwards, and A1C at 3 months, 6 months, and yearly afterwards. It's important to note that A1C at the beginning will not really be a good tool to use for screening for diabetes because first A1C is a 3 to 4 months average of blood glucose, but also because most of these patients have anemia. Dr. Markler was just telling me a lot of anemia, and that affects the A1C reading. So unless they have had no anemia, stable hemoglobin, it's hard to rely just on A1C. This is why the fasting blood glucose is a good tool at the beginning earlier. We use the same diagnosis criteria basically for the diagnosing diabetes in this population, which are random glucose over 200 with symptoms polyuria, polydipsia, fasting blood glucose over 126, glucose tolerance at 2 hours of 200 or more, and A1C of more than 6.5. Very important is that the diagnosis of post-transplantation diabetes can only be made at least after 6 weeks of the transplantation, because it should not include that post-operative hyperglycemia that can resolve on its own. So you have to wait at least 6 weeks before you label this patient with a post-transplant diabetes. So why it is important to address this diabetes in these patients? It's because, like in general population, diabetes is associated with macrovascular, microvascular complication, higher mortality, but also specifically in kidney transplant recipients, it can increase the risk of graft loss and the risk of infections. So it's really very important to first diagnose and then manage their diabetes. And specifically screen for diabetic nephropathy to make sure you optimize the chance for survival of the graft. Now, managing diabetes is, as you know, multifactorial. Dr. Markler covered very nicely the lifestyle changes that should be included in any patient, in the management of any patient with diabetes, blood pressure control, lipid control, and what I will be discussing is the pharmacotherapy. So usually immediately post-op, we use insulin to treat high glucose because of the steroids affect the dynamic changing. But then afterwards, we try to use oral agents or non-insulin agents, and only when this is not sufficient, we put patients on insulin. Now, unfortunately, because the number of patients who have kidney transplants and diabetes is much smaller than the general population, we don't have enough data to have clear guidelines on what to do. There is no one recommended first-line agent to use in these patients with diabetes. There is, however, some consensus basically on what is considered safe in this group. So drug selection should consider efficacy, side effects, possible drug-drug interactions, and the cost. So I summarized in this table what people could or could not use in post-transplant diabetes, not including the novel agents that I will discuss. I used the color code, so the green is what's usually acceptable to use, the red is what people avoid using, and the colors in between are a little neutral, and I'll talk about the metformin. So the two agents that are popular usually in chronic kidney disease patients and in kidney transplant patients are the DPP-4 inhibitors and the glitinides. These two agents usually are not significantly renally excreted. They do not cause significant hypoglycemia. Glitinides can still cause hypoglycemia, but much less than the sulfonylurea. Usually they're available and safe. Sulfonylurea, some people use it, but the risk with it is the high risk of hypoglycemia, especially if you have lower renal clearance. The one that you definitely should avoid is the GLPIRA because it's renally excreted. It can cause significant risk of hypoglycemia. Glipizide is the best one to use in this group. What about metformin? So in type 2 diabetes in general, metformin has always been the first-line agent to treat type 2 diabetes. In kidney transplant recipients, physicians might be, or providers might be hesitant to use it because of the risk of lactic acidosis if there is a decline in eGFR. However, that risk of lactic acidosis is really very, very rare. And in general, the threshold to use metformin has changed over the past few years. So now we can use it for any patients with eGFR over 45 compared to 60 before. And if the patient is already on it, as long as eGFR is over 30, we can continue and decrease the dose. So many providers actually do use metformin, especially if the kidney function has been stable for a long time in a kidney transplant recipient. You just have to be very vigilant of the kidney function and make sure you adjust as soon as you see a change. TZDs are actually, they're very, very good hypoglycemic agents to use. The precautions with kidney transplant patients are the fluid retention that can be associated with TZDs, and that might actually require use of diuretics, which apparently, in kidney transplant is not a very favorable thing to do because of the risk of increased toxicity of the immunosuppressants. Also, TZDs increase risk of bone fractures, and some of these immunosuppressants have that associated bone loss side effect too. But in general, it's an insulin sensitizer. If the patient has no issues with fluid, no known low bone density, and you're running out of options, it might be used, but with caution. Alpha-glucosidase inhibitors are basically, they slow carbohydrate absorption. They're very weak hypoglycemic agents. Their use usually is limited because of the GI side effects of bloating. There are some also backup medication that people can use, but they're not like the most favored one. Now, to tell you the truth, on the previous list we have, these medications now, if we have patients with diabetes in the office, beside metformin, which we use almost in everyone, the rest of the agents have become third or fourth line agent in diabetes. What we're mostly using are the two agents that I'm going to discuss today, the two classes of medication, GLP-1 receptor analog and SGLT2 inhibitors, and I'll explain why. But it's really, this is why I think it's important to figure out if what we're using for the general population with all their benefits can be applied to patients who receive a kidney transplant. They actually, more than anyone else, need to have very good diabetes control and very good metabolic control. So we'll first talk about GLP-1 receptor agonist. So just as a background, GLP-1 receptor agonists belong to the class of what we call incretin mimetics, along with the DPP-4 inhibitors. What is the incretin effect? I like always to refer back to this experiment because it really clarifies how they work. Incretin effect is the fact that if you give a normal subject IV glucose or PO glucose, which is the oral is in green and IV is in blue, the patients who receive the IV glucose make much more insulin and have a much better glycemic response than IV. And they're trying to figure out why PO glucose would stimulate insulin much better than IV. And the answer is because we have hormones called incretins that are secreted by our intestines. This is why they're called incretins, that stimulate insulin secretion, that you're completely bypassing with IV glucose. And then they discovered that this effect of incretin is lost in patients who have diabetes, and it might actually be contributing to the development of diabetes. So this is why pharmacologically they were trying to see how they can reestablish that incretin effect to improve postprandial hyperglycemia, and they came up with two different agents. So to explain what incretins do, so incretins are secreted by the intestines every time a patient eats, and they have different effects on different organs. First, they act on the pancreas. They stimulate beta cells to make insulin, But this is very important. It's in a glucose-dependent manner, which means if glucose is not high, it wouldn't stimulate insulin secretion. This is why they do not cause hypoglycemia, and this is why we really prefer them much more than glutamide or sulfonylurea. They would not cause hypoglycemia because they wouldn't stimulate insulin unless sugar is high. They also act on glucagon, which is a very, very nice, actually, addition in the effect, because glucagon causes a lot of hyperglycemia postprandially. They decrease GI motility, and they also act on the brain that has GLP-1 receptors, and they increase satiety. And of course, you know, these two effects between the gut motility and the satiety is what promotes weight loss. And now, you know, these medications have become the very, very significant weight loss medications on the market. Now, what's interesting is that the studies have shown in the insulin secretion that happens after meals, 75% of it is induced by this incretin effect. So this is why reestablishing it is going to be very helpful. So this is how these medications work, the 4 different mechanisms: glucose-dependent insulin secretion, decreasing glucagon, increasing satiety, slowing gastric emptying. DPP-4 mostly works on the glucose-dependent insulin secretion, but the GLP-1 receptor analog works on the 4 of them. This is why it's a much more potent medication to give. These are the GLP-1 receptor analogs that are approved to be used in the United States, and the ones now that we use much more often are the semaglutide and dulaglutide, because they're weekly injections, they're much more convenient, but we also use liraglutide. They are very potent hypoglycemic agents. The A1C reduction that can happen with them can be up to 2%, sometimes more, compared to most of all the other non-insulin agents would not lower the A1C usually by more than 1%. So they're very potent. The very nice benefit of them is the weight loss that can be up to 15% of weight loss with the weekly stronger GLP-1 analogs. So this is why in general in diabetes we like to use them. They're becoming almost like first-line agent for every patient. We like to use them for glycemic control, associated weight loss benefit. They do not cause hypoglycemia. They do not require frequent blood glucose monitoring. And they have these now proven benefits, cardiovascular and renal benefits that I will be discussing. Their side effects mostly are GI side effects. The patients experience nausea, vomiting, or change in bowel movements at the start of the treatment. Usually, with time, these side effects improve. This is why we start low and we titrate up. There are some diet modification. If you have patients, you can actually suggest that if they're having a lot of GI side effects, make the meal size smaller, avoid fat, stop eating when you're full. These things can decrease nausea. The reports of pancreatitis and pancreatic cancer happened post-marketing. There is an association that we know about, but we have not really established that there is a causative risk association. We do not know that they do cause pancreatitis or pancreatic cancer, but there is an association, and this is why we don't use them in patients with history of pancreatitis. There is also higher risk of gallstones with this medication. We don't use them in patients with medullary thyroid cancer or MEN syndrome because in animal models they have shown to increase the growth. And we have to be cautious if you have someone with progressive proliferative retinopathy with semaglutide, they noticed worsening retinopathy, and that could be related more to the rapid glucose control rather than the medication itself. Now, the major really benefit of these medications is that in their cardiovascular outcome trials, which are now required by the FDA for any diabetes agent, they showed to have a cardiovascular benefit. So it's a busy slide, but basically these are the trials. LEADER is the liraglutide, SUSTAIN is the semaglutide, and GWIND is the dulaglutide. And they looked at what we call the MACE, the major adverse cardiovascular events, which are a combined outcome of cardiovascular deaths, non-fatal MI, and stroke. And these medications, for the first time actually in diabetes treatment, we have a medication that directly decreases cardiovascular outcome. But as a secondary outcome in these trials, they looked at nephropathy. And what they found is that the risk of worsening nephropathy in all these 3 different GLP-1 receptor analogs was lower, significantly lower. And in each study, you basically see exactly that there is either improvement in the albuminuria or the improvement in the decline of the creatinine. And on meta-analysis, when the meta-analysis looked basically at this group, there is a significant overall decrease in progression of the nephropathy. However, if they exclude the patients who had albuminuria, it lost the significance. So basically what we know for sure is that in patients who have nephropathy with albuminuria, GLP-1 receptor analogs slow down the progression. So that's even, an additional benefit for their use. This is another example of GLP-1 compared to DPP-4 showing slowing of diabetic nephropathy. This is why if you look now at the American Diabetes Association guidelines, this is busy. I'm going just to zoom on the parts, on this first part. The guidelines now for us tell us that if you have a patient who has established cardiovascular disease or high risk, heart failure, or chronic kidney disease, regardless of their A1C, even if their A1C is 6.5, you should offer them a medication that's known to decrease cardiovascular mortality or to slow down chronic kidney disease. And these medications would be either GLP-1 receptor analog or SGLT2 inhibitors like I have shown. So we are giving it to every patient with diabetes who has cardiovascular disease or high risk of cardiovascular disease or chronic kidney disease. So, and this is why basically they have become almost first or co-first agent in use of type 2 diabetes. The low risk of hypoglycemia, the cardiovascular benefit, albuminuria benefit. They're definitely preferred to insulin. Before we get to insulin, you always try GLP-1 receptor analog unless patients have contraindication. And they're very effective in achieving weight loss, which is usually a major comorbidity in patients with type 2 diabetes. So beyond glucose control, weight loss will help the blood pressure, the lipids, all the other comorbidities associated with weight loss, with weight. So why not using these medications in kidney transplant patients if they're so great medications and they have so many benefits? So first, as it will be the answer to every time I ask this question, we have limited data. Unfortunately, in all the big trials that I showed, they do not include patients with kidney transplants. But specifically with GLP-1 receptor analog, there were two concerns. The first concern is because of the delayed gastric motility that I explained, there was a concern that it might delay the absorption of the immunosuppressant and then compromise the graft survival. We know that actually this happens, for example, in patients who are on levothyroxine. We've seen sometimes that we need to make adjustment once we start on GLP-1 receptor. Women on oral contraceptive pills in the titration phase, it might not be fully absorbed as well. So absorption might be an issue. So that was the first question. The second concern was the GI side effects. As I mentioned, in most patients, they will have nausea, vomiting, and sometimes diarrhea or constipation. And apparently, this is also a side effect that can happen with some immunosuppressant therapy. So combining these both GI side effects and having to adjust immunotherapy is not something desired in this population. So I summarized here the trials I found looking at GLP-1 receptor analogs post-kidney transplant. And as you will see, first, there are very few trials, and if you add all these numbers of participants, they're like, compared to the cardiovascular outcome trial that has 4,000, it's really very, very limited data. However, we do have some data. All of these are observational data, no randomized control trial. I will be going in more detail through like a couple of them. What I wanted to show here is that, there are other trials that I didn't put here. There were solid organ transplant patients who received GLP-1 and for diabetes, but it's basically similar findings. So they followed them, the longer follow-up was like for 21 months. And if you look at A1C and weight, they're either significantly lower or tend to be lower. If you look at the eGFR, either it has not changed, or in some trials, like the second and the last before second, there was significant increase in eGFR. And they looked at the tacrolimus dosage change, and it did not require any change in the dosage. So it was kind of a consistent finding, even their small studies, but it was consistent finding that it did not affect the immunosuppressant dose. This is one of the first ones that was published. It's a retrospective study, basically 17 patients, mostly were on liraglutide. It was efficient in reducing total insulin dosage. And again, here they looked kidney function, remained stable, immunosuppressant dose remained stable, none of the recipients experienced acute rejection. Sorry. This is another study of 15 patients who received GLP-1 receptor analogs. Very similar finding. Now it was more semaglutide. This is why you see that the weight loss and the A1C were more potent than the previous study. And again, no acute renal events. This study is not published yet. I found it online. It comes from Saudi Arabia, where they looked to 39 patients who had received semaglutide, and they followed them. Again, very significant decrease in A1C in weight, no change in eGFR or albumin to creatinine ratio. Here I specifically included the specifics for their immunotherapy, what they were receiving. It's important to note that the semaglutide was really started like over years after actually they received the kidney transplant. It was never right after. So the good thing that was consistent in all these studies, and there were additional more basic science studies, it showed that GLP-1 receptor analogs do not interfere with the tacrolimus and also does not decrease its absorption. So that concern so far has been, we have some reassurance for it. These are possible mechanisms on how GLP-1 receptor analog can have a favorable effect on the eGFR that we saw in a couple of these studies. And to conclude for GLP-1 receptor analog, so far, even though it's limited and basically observational study, we know that they appear so far to be safe and effective with no significant interaction with immunosuppressant therapy. And eGFR seems to remain stable. What about SGLT2 inhibitors? SGLT2 inhibitors basically work, as you know, by blocking sodium and glucose reabsorption at the proximal tubal level. It's because of that. So by blocking the glucose reabsorption, it decreases blood glucose, increases glycosuria. By blocking sodium reabsorption, this is how we think they get all the other cardiovascular and renal benefits that we will be talking about. So these are the available SGLT2 inhibitors in the United States. And so what's specific or what describes them as diabetes agents, first is that they're not as potent as GLP-1 receptor analogs. So A1C reduction is 0.5 to 0.7, but it is, of course, significant. They do not cause hypoglycemia, and we always like that when you're treating patients. They do cause some weight loss, not as much as GLP-1, but 2 to 4 kgs. And they also reduce blood pressure. Now, what are the side effects that we are concerned about? The most common one is urinary tract infection and genital infection. And that is something kind of expected because of the increased glycosuria. And it's very consistent across the studies. It is more common in women for the vulvovaginal candidiasis. The increased risk of UTI was not as consistent as the genital infection. This is important to know, there were several case reports of Fournier gangrene in patients using these. So it's always important to educate patients to seek medical attention if they have any urinary symptom, pelvic discomfort, fever. With the dapagliflozin, there was a question mark of increased risk of bladder cancer. This is why we don't use it in patients with bladder cancer. Beside the urinary tract infection and the genital infection, there is a question mark bone safety with these medications that was basically started by the CANVAS program, which was the canagliflozin cardiovascular outcome trial. It showed increased risk of bone fracture, but it was as early as 12 weeks after starting treatment. So this can't be through a lower bone density. It's really too early. We're not sure if it is because of some alterations of phosphorus absorption causing higher PTH, or it is an orthostasis effect that's causing more falls, but we know that there was a significant increased risk of fractures. Also with the canvas, there was a significant increase of amputation risk, and that is actually was very concerning. It was almost doubled, and most of the patients who had amputation had already underlying neuropathy. And that is why, even though this was not replicated in the other SGLT2 inhibitor study, that is why we do not use SGLT2 inhibitors in patients with history of ulcer or with history of amputation. Another significant risk is euglycemic DKA, and we have seen so many, in the hospital. So what can happen with these patients? They're losing glucose in the urine. Once they're not getting glucose, whether because they're NPO, they have decreased PO intake, or they're exercising too much, they just can go into a DKA, and we call it euglycemic because the glucose doesn't actually go up because they are depleted of glucose. So you would have a patient with blood glucose of 160 and severe metabolic acidosis. So education is very important with that patients, if they're going NPO or for a procedure, or if they're not eating well, to hold off the medication. These are the cardiovascular outcome trials with the empagliflozin, canagliflozin, dapagliflozin, and ertugliflozin. You see they involved thousands of patients and follow up for several years. And like the GLP-1, most of these medications did show improved cardiovascular outcomes. And empagliflozin actually was the first medication ever to show decreased cardiovascular deaths among diabetes medications. Also, renal composite outcome was a secondary outcome in these cardiovascular studies, and it was very consistent and significant that SGLT2 inhibitors had a favorable effect on the combined outcome of albuminuria, renal function, renal replacement therapy, or death of renal cause. But also for some of them individually, they did reach significance for decreasing that outcome. This is a meta-analysis that showed a very strong protective effect. And it was regardless of the baseline eGFR, even though less benefit is observed with more severe kidney disease. Here I just summarized the SGLT2 inhibitors trials. So at the beginning, these trials were basically done in patients with diabetes. But when they saw that secondary renal and CHF cardiovascular benefit, they did other studies that were dedicated for these outcomes as primary outcome. So for the renal effect, the first one to come out was the CREDENCE, which looked at canagliflozin in patients with diabetes. But here the primary outcome was a renal outcome. But then they expanded to include patients with no diabetes for both DAPA and empagliflozin. And they did similar studies for patients with CHF, with and without diabetes. And I can tell you the short answer to all these studies, all of them showed very positive effect. And many of them had to be stopped prematurely because of that strong effect. So for the renal outcomes, the difference between CREDENCE, DAPA-CKD, and EMPA-Kidney is the population, basically. So the CREDENCE was patients with diabetes and albuminuria. DAPA-CKD was dapagliflozin in patients with and without diabetes, but with albuminuria. And the empagliflozin one included patients with or with no diabetes and with or with no albuminuria, so all chronic kidney disease patients. And all of them showed and they kept lowering actually the eGFR threshold that they can use up to more than 20 in the EMPA-Kidney. And they all showed very favorable effects. And these are the possible, basically, mechanism on the metabolism and also on the hemodynamic effects. It's mostly decreasing that glomerular pressure that we think is inducing all these benefits. Some important things to keep in mind when prescribing SGLT2 inhibitors, because of the diuretic effect, if the patients are already on diuretics or if they have low normal blood pressure, you have to adjust that. Otherwise, they're at risk of orthostasis. And if they are on insulin or sulfonylurea, you have to reduce that to decrease the risk of hypoglycemia. So who would be good patients to use SGLT2 in diabetes? Almost everyone, unless they have contraindication technically. So anyone with cardiovascular disease, with CHF, with CKD, anyone who desires weight loss, anyone in whom you're concerned about hypoglycemia. Cautions are patients with low blood pressure, patients at high risk of amputation, patients with history of DKA, of fracture, recurrent UTI, type 1, very low eGFR, which we have discussed. So again, if you remember that part of the guidelines, anyone with cardiovascular disease, CKD, or CHF should be actually on SGLT2 inhibitors. So if you have a medication that has proven so strongly to benefit chronic kidney disease, the question, can we use it in patients who have a kidney transplant? And again, here we have concerns. And what are the concerns specific to this medication? Because of the effect on the urinary tract infection, you know, UTIs can be very harmful, of course, if someone has one kidney. And to start with, they can be also more common in renal transplant patients. The other concern was a possible risk of acute renal failure right when you start the medication. That has been observed in general diabetes population, and it's thought to be induced by effective volume depletion. This is why it's very important to make sure patients are hydrated, if they are on diuretics or if they have, I don't know, vomiting, diarrhea, to make sure they remain hydrated. So what studies do we have on SGLT2 and kidney transplant patients? Most of them, except for one, are again observational studies. They included small number of patients, but they all showed actually benefits. They showed improved glycemic control, weight loss, blood pressure reduction. Kidney function was stable in all these studies. No reported serious adverse events, including DKA or acute rejection. And no difference basically in adverse event when compared with other patients who did not receive transplant. I picked just a couple of studies. This one is the only randomized controlled trial in SGLT2 in kidney transplant patients. It was done in Norway. It included 49 patients who were randomized to empagliflozin or placebo, but 1 year at least after they have been stable after the transplant. It showed significant decrease in A1C, significant weight reduction, no difference in eGFR, immunosuppressant dose, or side effects. This other study was an observational study, but it included a bigger number of patients, this time 339 patients from Spain, and they specifically looked at the UTI risk factor because that is one of the major concerns. They found that 14% of the patients had UTI, 10% needed to stop the medication because of UTI, but they were able to identify specific risk factors to having UTI in this population, which are being a female and having had a UTI within 6 months of the start of treatment. And then it also confirmed the benefits we knew from before, which are body weight, glucose control, decreased serum uric acid, decreased urine protein to creatinine ratio, increased magnesium, increased hemoglobin. So when you look closely at the UTI in this population, they're very similar to UTI in patients who have no kidney transplant. And they're also, in terms of incidence, but they're also similar to kidney transplant patients who had no SGLT2 inhibitors. So it's not really an increased risk compared to the other population. And finally, this study was the largest. It included 2,000 patients, 226 had received SGLT2 inhibitors, and it was also a longer follow-up. And again, it showed very consistent finding, which is basically improved A1C. What was new in this study is that they did actually look at the graft failure and serum creatinine doubling and all-cause mortality, in addition to the immediate effects on A1C and blood pressure. And they did see that overall, the eGFR remained stable. Some patients did have the dip I mentioned at the beginning, but they recovered afterwards. So this is the first trial that actually shows that it is safe in terms of survival or renal protection in this population. These are ongoing trials. So the first one is what we discussed, and all the others are ongoing randomized control trials. So this is really very promising that people are looking at more basically evidence about the use of these medications. So in conclusions, we have limited data for SGLT2, but these data are encouraging, and they're showing that SGLT2 inhibitors do improve glucose, weight, without really increasing the risk of UTI or amputation or euglycemic DKA compared to the non-users. The UTI was the most common side effect. And we have to note that, like the GLP-1, these medications were started at least after 1 year of the transplant. So finally, what do we conclude from this talk? First, it's really very, very important to control glycemia in patients who have received kidney transplant, because it will affect the graft outcome, but also it will affect morbidity and mortality. And being able to control the weight and adding to these metabolic benefits would be very helpful for these patients. Although the data is limited, they are encouraging so far in terms of safety of GLP-1 and SGLT2 inhibitors treatment. But we definitely need long-term outcomes to look at the renal graft function and the survival. But so far, everything really is falling in line with what we have found in the larger studies of non-transplant patients. Also, some encouraging finding is the absence of significant drug-drug interactions. So none of these all observational studies reported change in the dosage of the immunosuppressant. And it's very important to understand how these medications work and what are the precautions for them to choose the right patients, basically, for them. Thank you. If there are any questions, I'll be happy to take them. You mean once they're on the treatment? Yeah, you know, it depends on how stable their diabetes is. So someone who is on insulin, usually we ask them to check several times a day their blood glucose. But if they are only, let's say, on GLP-1 receptor analogs, they do not need to check that often because they do not cause hypoglycemia. And now we have the continuous glucose monitors, which thankfully the coverage is picking up for this. Many patients who can have them actually are having them. So the continuous glucose monitoring, it's like a device that the patient puts that reads their glucose for 2 weeks. They replace it every 2 weeks. They can see their glucose all the time, and you can set it to alarm them if it's going low. But the big advantage of GLP-1 receptor analog, for example, compared to insulin, one of the big advantages is that it does not cause hypoglycemia, and therefore they do not need to check that often. Whereas someone on insulin, they need to check every time they're injecting insulin to make the adjustment. With GLP-1, there is no adjustment that's needed. The GLP-1 receptor analogs, I usually, at least have a contact either by phone or in follow-up at 1 month, because it's a titration. So the weekly doses for the semaglutide and dulaglutide, you titrate every 4 weeks. So you start at a subtherapeutic dose. So usually at 4 weeks, I check with them to see whether they're tolerating it well and they're ready to increase the dose. Then at also another 8 weeks, I recheck. And then once they're tolerating it and they're stable, you can start spacing. It's I don't have that many patients who have kidney transplant, but in general diabetes population, these medications have been really great. They work very, very well. They have very little side effects, and they have so many benefits. And the weight loss that comes with them is so helpful, not only for diabetes, for all the other conditions the patients have that are related to obesity. So the question is about any data of effect of SGLT2 on diabetic neuropathy. I'm not aware of any. It would be interesting. There are things that we have observed with GLP-1 receptor. Let's say the worsening of retinopathy. Sometimes, the retinopathy can worsen, and we're not sure if it's because of rapid improvement of glucose. Same thing can happen with neuropathy. If they were very uncontrolled and they improve quickly, sometimes the neuropathy can worsen. or it can improve, but I haven't seen anything related to the medications themselves. Dr. Salih?
Thank you very much for a wonderful talk. So what is the future looking like? Do we have options for once a day, like a pill form, tablets?
For the GLP-1?
Yeah, GLP-1.
Yeah, so now the liraglutide is once a day. We have the once a week semaglutide and dulaglutide, and we have the oral form of the semaglutide.
Okay. I didn't know that.
But there are, for the GLP-1, but there are so many studies ongoing now. You know, now we have dual GLP-1 GIP analogs, which is the tirzepatide, and then there is a triple GLP-1 GIP glucagon analog that's coming, and all of them will have oral formulations. So it's a very, very dynamic field now. It's research is phenomenal in this field because now they're using them for weight loss as well, and it's been a very big game changer in weight loss.
Yeah, as a follow-up question, did you find any data on the combined GIP and GLP-1 drugs with transplant?
No, I don't know if actually, because it was just approved like last year for diabetes. So I think people are looking, but I haven't found data. But I'm sure it will come. The dual is more potent than GLP-1 receptor analog in terms of A1C reduction and weight loss. But we still don't have data on renal benefit and cardiovascular benefit. So it's just, it's following. It will take a few more years, I guess.
We have a question from Diana Muller on Zoom. The question says, Doctor, what is your opinion on SGLT2 inhibitor in dialysis patients?
In dialysis patients, I don't think any is approved in dialysis patients. Now, I have to say, actually, I didn't mention that. The glycemic effect decreases very much when the kidney function decreases. So once the eGFR is less than 30 to 45, we lose the glycemic effects because you need that normal kidney function to excrete the glucose. So usually now when it's used below these eGFRs, it's for CHF and kidney indication, not for diabetes indication, because we don't expect a glycemic effect when eGFR is low. So for sure in dialysis, it has no glycemic effect. What would be the other indications? Kidney protection, I think it's too late when they're on dialysis. CHF protection in dialysis patient, I don't think there is any data on that. It would be, and especially if the patient is not urinating, I don't know how it will give any benefit.
Thank you.
Thank you. Thank you very much. Thanks.